there's like 7 you here, and then the rest of the people. Okay, so here's wrist. Here's a neutral wrist, right? And let me see if you guys can see this. All right. All right. So here's neutral wrist, and this joint action here is wrist pronation. This joint action here is wrist supination. This is neutral. Me going into pronation, this is going with gravity. So this is going slower than gravity. This is an eccentric movement. So it's not the pronators that are producing this movement. If I just kind of tilt this way a little bit, gravity is going to take over. Gravity is pulling me into pronation regardless if my pronators are on or not. So the reason the muscles that are engaged here are actually the supinators that are working eccentrically. They're controlling this motion. And then if my hand's flat on the table and I go back from a pronated position to a neutral position, this is wrist supination. This is against gravity, so this is a concentric action. This is the wrist supinators working concentrically. And now if I go from this position, neutral, and then I go continue on this way to now wrist supination, this is a continuation of supination. I'm going from neutral. I went from neutral gravity to with gravity. This is an eccentric phase of now the wrist pronators working eccentrically. I go back to neutral. This is wrist supination. That's the wrist supinators working. I'm sorry. This is supination here. I'm going back into neutral from supinated. Those are the wrist pronators working concentrically to that point, and then the wrist supinators working eccentrically from that point. Wrist supinators working concentrically, wrist pronators working eccentrically, and back and forth. So I'll let you take a second to digest that. And that's going to be that's really what functional anatomy is being able to identify who are the agonists, who are the antagonists. And I think the biggest separation of this class from your static anatomy is appreciating the eccentric phase. When you learn muscle action, it's always based on the concentric. These are the biceps brachii are your elbow flexors, or their shoulder flexors, or pec major is a horizontal adductor. But when we learn it that way, particularly your role as in therapeutic interventions, particularly working with people with dysfunction, or if you progress into people with performance, understanding that we spend actually just as much time in the eccentric phase as we do in the concentric phase, and it's just as important. So really being able to identify and visually and mentally process the difference between going with gravity, being able to see a joint action, like for instance, elbow flexion, and then even though I'm producing elbow extension right now, this is an eccentric activity. Even though it's elbow extension, it's not my elbow extensors that are working, it's my elbow flexors that are working eccentrically to control that motion. So as we move into the hip, and particularly in the spine, but most importantly into the hip, as we start to, because we're going to do lower extremity, then we're going to move back up into the spine to incorporate pelvis, and then look at the pelvic girdle and shoulder girdle with gait. Gait and gait cycle and gait dysfunction is all eccentric loading and capturing that energy. So being able to identify that. And so where the complexity of it now is, now you have that abstract concept of concentric eccentric, combining it now with being responsible for all the muscles that are responsible for there. Now, no longer it's just elbow flexion and extension. It's, are you talking about the long head bicep, short head bicep, brachyradialis, brachialis, or all of the above? And then appreciating some of the neural structures that are going there. Any questions? It looks like most of you guys filled out that survey, and some really good feedback. Thank you for not saying that the one thing you would change is the instructor, so that's good. But some of the feedback I want to address here. So I think some of the things were really great ideas, and I think what I'm going to do is I'm going to start offering a quiz midpoint towards the, not midpoint, but like the week before, like after all the modules are done. We'll start offering a quiz, and the quiz will be either a recycled exam that I used in my KIN 236 class, like the functional anatomy class, and you'll be able to at least take basically what I'm going to do is I'm going to offer you what's it called, a dry run of the exam. You'll take it, and your points, there'll be open book, open notes. You can take as long as you want for it. It's meant to be an active study tool, so that at least when you actually open up your real exam, the one that's going to count for most of your points, it's not a shell shock. So that's what we're going to do for the next 3 units for lower extremity, trunk and spine, and gait. And then the grading of the labs, there's no answer key for that, and there's just and I agree, there's so much material. I'll see what I can do to push that through, but when I grade those are really meant to be. Here's the honest truth: those are meant to be a buffer so that all the points in this class aren't on the exam. If that was the case, about 50% of you'd be failing right now, but most of you are everyone's at a B or an A or higher because of those lab reports. And the way those things are working out is that those are meant to be active study tools. It's forcing you to go through the material. And when I grade them, I think I had mentioned this last live session, I'm grading those based on general completion. I'm not looking at I'm maybe picking 4 or 5 things, looking at them, and if they're satisfactory, I'm giving, if they're 90% completed, you're getting 90% of the points. I rounded up to an A. If they're partially completed, you're getting, if they're 0. So you're usually getting 100% of the points or 0% of the points based on if you're turning them in or not. So those are meant to be active study tools, but you should be focusing most of your attention on trying to get as much points in the exams as possible, because that's where it's going to be detailed out. The other concern was with the textbook and the content, and it doesn't matter what textbook we're using. I could be pulling images from Wikipedia and just using old style images. Muscle attachments are muscle attachments. Concepts of concentric and eccentric are concepts of concentric and eccentric. It actually behooves you to be exposed to different graphics, different images, different illustrations to kind of see it in multiple aspects. And it also you should be encouraged of you looking up stuff online as well, looking for other components. So even though I use the whatever book I use, I can't think of it. The Newman textbook. I like it because it's different images. I still like the Limpert, the clinical kinesiology book, but it's just different, and that's really why I like it. It's different. It's a variety. Instead of having just one image of looking at the elbow flexors or the wrist motions, you have 2 images that you can look at now. And then there's all types of resources. I mean, anatomy is so vast online, and YouTube videos. There's tons of content out there. So I encourage you to try to look at it from different perspectives. But I mean, the basis of this is to really appreciate the joint actions, being able to visualize the articular system, understand the loads with gravity. So are you concentric or eccentric? And then appreciate which muscles are participating in that particular movement. So whether you get that from a YouTube video, whether you get that from one of those pre-lab activities, whether you get that from your textbook, whether you get that from the videos, I'm trying to diversify the ways you're seeing it so that it sticks, or you can conceptually see it better. So if that's confusing for you, then what I would recommend is just stick to the book. If you stick to the book, you probably are not going to go wrong, right? Because you're going to have all the muscle attachments there. You're going to have all the innervations. And as long as you understand the concept of concentric eccentric, you'll be okay. I don't think that's going to be sufficient to fully understand or appreciate movement. And that's why the videos come in. What the videos are really doing is, I'd watch the videos first, get that information coming in, and then go back to the textbook to review those materials, and then just really make sure that you have your chart for the innervations, you have your charts for muscles, muscle attachments, and then you should be studying, making sure that this is concentric, this is eccentric, this attaches here, this attaches there. If this nerve is damaged, so just kind of understanding how it interplays all together. And that's where I saw a lot of the weaknesses was at. And it's not uncommon. The first exam, people need that little wake up call of like, oh, I should have probably understood my attachments better, or I should have probably, when they see in the study guide, or they say, hey, know all the attachments, they didn't realize that really meant know all the attachments of the muscles that we're dealing with, right? So it just puts a level of, right, it's not quite the same level of studying that you need for your anatomy class, but it's because we're focusing just on the musculoskeletal system, but it should just focus your attention just on that one area. And we're just looking at like the arm, and then we're looking just at the leg. The hand is complex. I do admit that there was probably a greater percentage of questions on the wrist and hand that I probably would have liked. But that's not going to be the case for the next couple exams. The lower extremity is going to be it's not going to be as complex. The foot is more appropriate to us for the gait cycle because we're loading. And then when we get into the trunk and spine, the amount of muscles that we get are even less. So shoulder is the most complex. Normally when I teach this class, I actually teach upper extremity last in the unit. I usually start with trunk and spine, go to the legs, and then move up. So we actually did the hardest and the most complex of the modules for the structural, just because of the sheer volume first. And it's going to get a little easier with the lower extremity. And then when we get to trunk and spine, you're going to be experts already, right? And there's going to be less muscles to go through. So if you're stressed or worried about the rest of the exams, I wouldn't be. Everyone's doing really well in their aspect. It's to be expected to this exam to be a little bit of I mean, it's easier because it's a little bit more focused content, but harder because it's a different way of studying. But the subsequent exams are going to be better, especially since we're going to have a quiz and you'll have some exposure to the questions a little bit. But again, you've kind of had the exposure to these questions now. It's just going to vary from now. It's talking instead of talking about the elbow, you're talking about the hip. Instead of talking about the wrist, you're talking about the ankle. So, any questions?
That you're going to post for us, like a pre-quiz for the test? Is that going to count as points or just for review?
I can't. I technically I'm not supposed to introduce new graded assignments for the because of, per the syllabus, but they would be easy points. So I could leave it up to you guys. So we can see how the first one goes, and if they're completed, we can do that. I think in the syllabus I have some points allocated to the online learning modules, which that's just so I can probably rearrange those. But I'm going to do what's ever best for you guys. So I think the most
Like a
important thing
poll
is
or something, but I think I personally like how you're already doing the points as it is. So if it's just open review, that's just another study tool. So that's
yeah,
helpful.
I think that's what I'm going to do it for. Right, just to kind of have it as a low because I think let's put it this way: if I didn't have those pre-lab and the lab assignments, I would definitely made it for points. But since you have that buffer to kind of diversify those points a little bit, the way this works is if I didn't have those pre-lab assignments, one hiccup on an exam would crush you and then you're out of the program, and so that's not good, and it then puts too much stress and anxiety on each individual exam. So the fact that those pre-labs and labs, even though they seem like a lot of work, they really are offering as like an insurance policy or a buffer for the grade to kind of protect you from. It's a hedge for messing up on one of your exams. So yeah, they won't be quiz, they won't be points. It'll be up to you if you want to take them for study. Just a study tool. Cool. Okay, so moving on then to the next. Well, no, this is not what I want. This is what I want. Okay, similar to last unit, the way that the book goes that you have the pelvic girdle and then you have the hip and then you have the knee. You have some combination. So you'll see that the videos that I have posted, they are combined, and it's hard to talk about the pelvis by itself without talking about the hip joint. So I think my videos on Blackboard through YouTube, they have those combined, so you kind of look at them both. Could be a little overwhelming, but just keep in mind that you have 2 weeks to go over that material, not just 1 week to crush that all in. So I combined hip and pelvis together. The way that this book breaks it up, it's pelvis first, then hip. So this week should be technically pelvis. Next week should be technically hip. But the way that I have it presented, I show them, I talk about them at the same time, so that you can appreciate the integrated function of that. The pelvis is the gets a lot of attention when we look at like core stability. We look at dysfunction. I think I spend, and I don't know if I shared this with you guys or not, I think I spend 90% of my outpatient orthopedic time teaching people how to control their pelvis. Like it's this relationship. And when we talk about trunk and spine, we look at like lumbar issues and back issues. The spine gets all the attention, like we got these braces for our back, or you look at ergonomic chairs and it's looking at the lumbar spine. But really, the most important aspect is position of the pelvis. And the reason is that when you appreciate here the pelvis, you see that the pelvis and the sacrum, um, they're there's debate in the fields, and it depends on how you're looking at this, of how much movement actually occurs at that sacroiliac joint. And that's the relationship between the sacrum, which is the foundation, the base, the core of the spine, and the transition point with the pelvis. And where the pelvis goes, the sacrum goes. And when you look at transverse plane motion, so rotation, or you look at frontal plane motion, so like ab and abduction or lateral flexion, there is very little motion because of the structure of that sacroiliac joint. But in the sagittal plane, because of the way that that plane, the shape of that joint is, there actually is a little bit of motion. So if you ever do a quick literature search about how much motion actually happens at the SI joint, you'll find mixed reviews. And the reason why you'll find mixed reviews is more so because people aren't looking at it from that complex perspective. They're just oversimplifying, saying, yeah, there's not a lot of movement there. But there actually is a lot of movement there, and in the sagittal, not a lot, but enough that 3 or 4 degrees that can make or break pain, L5S1 disc herniation, functional performance, and looking at like appropriate pelvic positioning that would lead to spinal type components. We'll talk more about it in gait, because in gait you have one leg moving forward, the other leg moving back, and so you kind of have you have a need for that pelvis to kind of separate a little bit and have a little bit of give. You have the pubic symphysis here that gives a little bit, but you do have some motion. But this pelvic positioning is also dependent upon the hip musculature. So when we look at like tight hamstrings contributing to back pain, or weak hamstring muscles contributing to back pain, or tight or weak hip flexors, that pelvis, almost all the muscles that control the hip, they either anchor or cross the pelvis. And so this becomes a big relay station for force and for transmission. And particularly when we get into gait, the load transmission that's coming up through the leg, into the through the pelvis, into the sacrum, and then up through the opposite contralateral side of the body. So the pelvis is really an important aspect of what you will probably be doing in a clinical setting. If you're in an outpatient setting dealing with people with back pain, or even hip and shoulder issues, I'm sorry, not hip and shoulders, knee and shoulder issues, a lot of that can be traced back to poor lumbopelvic mechanics. And 99% of it is probably due to the amount of time that you spend sitting and the piss poor posture that you have when sitting, right? That tailbone tucked under type component. So it seems like a very simple area, like, oh, you have a pelvis and you have your sacrum, but there's so much dysfunction that comes here, more so because of the interplay between the lumbar spine and the hip. The pelvis becomes the primary determinant of how you can separate between a female skeleton and a male skeleton outside of sheer size. The pelvis is a little wider for childbearing, kind of have that space opened up a little bit. This space right here, that is this bowl at the bottom, this makes up the pelvic floor musculature. And the pelvic floor musculature, as we'll talk about when we get into the trunk and spine, that's a critical part of core stability, or at least the hydraulic ability for the lumbar spine to resist force. So you have the diaphragm on top, the pelvic floor on the bottom. And so that whole bottom here that you see is filled in with this bowl of pelvic floor musculature. Here's a nice lateral view of the sacrum. So you can see the sacrum here. You have 5 fused vertebrae, and then you have your 3 to 5 fused vertebrae for your tailbone. This is a pelvis that was cut in half. So you're seeing if you're looking from the left side, you're seeing the right medial side of the pelvis. This is where the pubic symphysis is at. And again, the thought process here is where the pelvis goes, the sacrum goes with it. And so the pelvic positioning really sets the tone for lumbar stability. And then the pelvis depended upon, you can't see from this view, but let's see here. You can't see from this view, but then the femoral acetabular joint, or the hip joint, where the femur comes into the pelvis, that is critical in terms of allowing muscles to, or at least the length tension relationship of the muscles, to allow the pelvis to move in appropriate positioning. So you're kind of in a short area here, like from right there to there, you have the largest muscles of the body coming in, and you have key positioning that, if something's off there, will create a domino effect all the way up the chain and all the way down the chain. Okay, so you have the SI joint, which we're talking about, and that's the relationship between the ilium and, the ilium and the sacrum, and the okay, good. This book does go into it. You get this. Doesn't show a good view of it, does it though? So there's your sacrum. It's talking about nutation, counter nutation. See, this is why I'm going to switch over now to the other book to look at. Let's do this instead because I don't think it's So you're let me flip back over here real quick so you can see. So your textbook here talks about this this counter nutation and nutation, which is SI joint motion. This is motion that only occurs in the sagittal plane. So as I had said earlier, the way the structure of the sacrum is that it doesn't really allow for any kind of transverse plane motion, so no twisting or rotation, and it doesn't allow for any kind of frontal plane motion. So the frontal plane motions are coupled. So when one pelvis is coming down, the other pelvis is going up. And same thing with pelvic rotation. If you're doing right pelvic rotation or left pelvic rotation, the both halves are moving together in unison. The only place that you really have any kind of separation is in the sagittal plane with like hip flexion on one leg and hip extension on the other. So thinking about doing the splits, that your pelvis is actually going to be split a little bit. And so what happens is you get this movement of the sacrum related to the pelvis, and you get this concept of nutation and counter nutation. And I think in my video I have a pretty good image of this for the nutation counter nutation. But you can kind of see here so real quick too on terminology, you have the instead of the sacrum moving on the pelvis, you have pelvic motion in itself. And so you have this term called an anterior pelvic tilt and a posterior pelvic tilt. And an anterior pelvic tilt, if you want to visualize the pelvis as a bowl, if that bowl was full of water and you tilted that water forward and the water was coming out of the front, that would be an anterior pelvic tilt. And if that bowl was full of water and you tilted the pelvis back and the water was coming off the back, that would be a posterior pelvic tilt. So if you had a tail and you were tucking your tail between your legs, you would be doing a posterior pelvic tilt. And if you were trying to sit really tall or arch your back or stick your butt back, you'd be doing an anterior pelvic tilt. So that anterior and posterior pelvic tilt is happening at the pelvis. So the femur coming in, it's using the femur as an axis. But if the back is kept relatively stable, so let's go back to the book here real quick. So if you allow the spine to move with the pelvis, so if I do pelvic motion and the spine stays neutral, there would be no nutation here. And if I do posterior pelvic tilt and the spine stayed neutral, I would be doing just posterior pelvic tilt. But if I kept my spine relatively straight and then did like an anterior pelvic tilt, you're going to get this nutation here. So anterior pelvic tilt, but the body is staying back. This arrow shouldn't be here. And then if I do a posterior pelvic tilt, so if I allowed my spine to come with it, like the pelvis is coming back this way, or tucking my tailbone under, I am getting this counter nutation. So it's just talking about the relationship of the sacrum moving independently of the pelvis. And if you get into different types of manual therapy, if anyone is working with like women's health, they'll look at and I say women's health, but it's really pelvic floor health. It just women tend to seek those type of care more. Understanding this sacral relationship in an aspect of the pelvis becomes an important part of your treatment components. So you have your bony structure here, and you can't really appreciate from this view. If we were in class, I'd be able to show you a model, but you can see that there's the way that the curve and the way that this sits in. It kind of gets the sacrum kind of wedges into the pelvis. It just the way the structure is. It doesn't allow for any type of transverse plane motion or frontal plane motion, but it does allow, because of the structure, the shape. It kind of is a slice that comes through here, allows for 1 or 2 degrees of the sagittal plane motion. But you have quite a bit of ligament structure crossing here. And again, the argument would be if you didn't have mobility there, a lot of movement there, why is there so much ligament structure supporting that? And let's see here if we can see a video. Let's go here. Let's just look at this real quick. So if you can appreciate here is every time you take a step, you have a single leg hitting the ground. You have all this force coming in from the pelvis or from the femur into the pelvis, and then that force, that load is being transferred through the glute, right? The glute max, the largest muscle of the body, and it's actually trying to transfer that force from the right glute through the left latissimus dorsi, and the right leg is coupled with the left arm. And so you have this huge force that's coming across through here. And then let's look at this. Oops. You've seen your anatomy charts and you've seen this big band of diamond tissue here, this white stuff here. And if you think about it, your glute max is your largest muscle of your body. Your latissimus dorsi is your second largest muscle of your body. And you have your external oblique, internal oblique, and transverse abdominis. So the key muscles, the largest trunk muscle rotators of the core, all of them coming in and interconnecting into this fascia. And so this X-like pattern, this posterior chain that you see here from the glute max to the latissimus dorsi, there's quite a bit of force transfer of energy coming through here. And if you think about the way you walk, your right leg and your left arm, they work in unison. So as your right leg is going forward, your left arm's going forward. And at the same time, your left leg's going back, your right arm's going back. And so you're getting this huge amount of like shoulder girdle going one way and pelvic girdle going the other. Well, your pelvic girdle is your pelvis and your sacrum, and that's twisting on the spine. And so that SI joint is responsible for maintaining that appropriate positioning during that movement, because it wants to try to minimize as much movement as possible. So you maximize the amount of force transfer that's coming through here. And the way you want to visualize this is as these muscles are generating force, so these are concentric. So this, I don't have my line here, but this line here, at the very same time, these muscles are trying to conserve or store that energy. And so you're getting this huge transfer of energy between the left glute, right lat as they're contracting, and at the same time, your left lat, or your right lat and left glute are relaxing, and they're transferring energy back and forth. And so that's why you have this really built up ligamentous structure. Where am I at here? Sorry. You have this ligamentous structure here that is meant to transfer those forces through. And so you have like your sarcotubuous ligament here that your hamstrings are attaching through here. And this is where, I don't know how many people, how many of you follow like Tom Myers for anatomy trains and looking at these fascial relationships and these different types of tissue trains that are kinetic chains that are through the body. But this is one of those really obvious ones that, if you have someone that has chronic hamstring pulls or hamstring tightness or issues in their back, that they're going to be looking at this connection between the left heel hitting the ground and all that force being transferred up into that right shoulder and that arm coming back. And so a lot of these ligament structures tend to be overused sometimes, so it can be strained. And this is also the site of where your sciatic nerve starts to make its appearance. So you have your L4, L5, L3 coming down, and it has to come through here, and with some of the sacral aspects, and some of these tissues can get so inflamed and so irritated that you have flare-ups of sciatica, and that sciatic pain goes all the way down to the heel, down to the foot, and that's usually sourced from the from the piriformis and some of the piercing of that nerve coming through this structure, these structures right here. So again, it's an innocuous area. It's not a lot of movement. It's not like the shoulder where you're looking at all this available range of motion, or the hand and wrist. There's very little movement. You're talking about 3 to 4 degrees of movement, but a lot of structural support because of the amount of force and the amount of functional dependency that's happening in this area. So in contrast to that, when you have this huge structural support on a relatively bony, stable area, when you look at the front of the pelvis, the other movement area, you don't really have that much muscular support. And you have some of your adductor muscles coming in and attaching down here through the pubic bone, and you have very little of the abdominal musculature attaching here. You have a little bit there, but it's mostly attaching into this inguinal ligament. And this point right here is your ASIS. That's the part of your pelvis that if you're standing or sitting, you can palpate down. That's the protuberance there. This becomes a really, when we get into trunk and spine, we'll be talking a lot about this in terms of an anchor point or attachment point. But most of the hip musculature in the front, you have your iliopsoas, which originates up here in the ilium, and then you have your psoas, which actually is originating in the lumbar spine. It's more of a spinal muscle, but it comes all the way down and through here. But you don't really have a lot of structural support back here. And the reason is this: think of this as like what a vertebra is to the back. It's more of a shock absorption to allow movement. It should be fused, but since we do have so much of that independent motion, we do need to have a little bit of that buffer to kind of allow that shock absorption. So not a lot of stability needed here because most of the force is being transferred in the back through these structures here. So this is now where you're starting to look at the pelvic positioning based on the where the pelvis goes, the sacrum goes. And again, we haven't gotten to the spine yet. Well, that's our next module, next unit. But you can see that when you have this anterior pelvic tilt, so you're kind of bring your hips back, you're trying to pour water out of the front, you're going to have an increased curvature of the lumbar spine. And then if you tuck your tailbone under because you're doing a posterior pelvic tilt, you're going to get a flattened aspect of the spine. And where you really want to be is you want to be in this lumbar neutral, the spinal neutral, where you have a nice plumb line. The cervical spine is stacked on top of each other. You have a nice pronounced thoracic curve, cervical curve, and lumbar curve. But all of this curvature is all dependent upon your pelvic positioning. And your pelvic positioning is dependent upon the hip muscles that are crossing the hip joint, right? How strong or weak your hamstrings are, how strong or weak your hip flexors are. And if you spend a huge amount of time, like most Americans, most people are doing, sitting down in a shortened hip flex position and a semi-lengthened or mid-range hamstring position, and you don't visit the extremes of hip extension, or you're not doing a lot of deep squatting, you're going to end up with this chronic positioning where you have a stacked spine and you're putting pressure on the vertebral discs here, and that's why we have a large, outside of the thoracic stabilization from the rib cage, that's why we have a large predominance of disc herniations in the lumbar spine and cervical spine because of lack of curvature from really bad posture or from pelvic positioning. And it's not because you're not having enough back strong muscles and you're trying. Most people, if like probably half of you right now on this call, when I bring up the term posture, you probably are all sitting there adjusting, trying to arch your back, and you can arch your back till you're blue in the face, but unless the pelvis gets in the right position, your positioning is off, and you're going to have a hell of a time trying to relax these muscle tissues. So posterior, anterior pelvic tilt, I think I talked about that already. This is showing your pelvic neutral. This is the anterior pelvic tilt where the ASIS is moving forward. So if this is a bowl of water, it's coming forward. And posterior pelvic tilt, like you're tucking your tailbone, or if you had a tail like a dog, you're tucking your tail underneath between your legs, and the water's coming back. So the pubic symphysis is pushing out further than your ASIS. And I'm sure in your pre-lab or your lab activities, it has you do a little bit of a posture assessment where you're assessing pelvic neutral. And if you were working with your patient and you just wanted to quickly assess, you can just put a piece of paper or a magazine or a clipboard, and you have them hold it, put it right in front. And in a pelvic neutral position, the top of their pelvis is ASIS, the hip bone that protrudes out by the waist. That should be hitting at the same time the pubic symphysis is. That plane should be perfectly perpendicular to the floor, and that's a pelvic neutral. Now, there's a little bit of variation in people because of the amount of tissue that's there, but that's relatively pelvic neutral. So if you look at from the anterior view and you look at the frontal plane, you can have this hip hike type situation. And you're going to get this a lot where people proclaim that they have one leg longer or shorter than the other. And although that could be somewhat true, 99% of the time, it's not because one leg is actually longer. If they had a fracture through their growth plate when they were young, perhaps they have one leg shorter than the other. If they had hip surgery or they had some kind of surgical intervention, but for the most part, the leg length or arm length discrepancy, any kind of limbs, they're usually minimal, like 1 or 2 millimeters. We wouldn't even notice that big of a difference. When you're talking about more than 1/4 of an inch where you need like a heel wedge, it's usually related to this frontal type movement where you have one hip higher than the other. This is usually related to scoliosis or some other type of weird thing going through the back or through the pelvis itself. And let me see if I can do it in my video here. Yeah, I'm not going to be able to do it. But if you stuck your hands out in front of you like you're walking like a zombie, right? You could, from that position there, you could make one arm. Let's see if I can try to do it here. You can make one arm longer than the other, and you're not changing the length of your arm. What you're doing is you're changing the carriage angle of your shoulder girdle. So you're protracting here, retracting, but if you look at your fingertips, let's say you try to protract your shoulder, your left finger is going to be longer, your left hand is going to be longer than your right. But you didn't really change the length of your arm. It's just that the starting points changed. And that's what's usually happening with the leg length discrepancies. It's usually related to a pelvic obliquity, right? You have one ASIS or one anominant pelvis higher, one side higher than the other, or vice versa. And you can kind of see that here, right? You got the one hip. And this hip hiking, like raising one hip up or one hip down, is a normal part of standing on one leg, part of the gait cycle, so you can get that foot clearance during walking or ambulation. The problem is when you're at a resting standing position, do you have this pelvis in a neutral position, or do you have one side higher than the other? And again, most of this is going to be a little bit of the abductor strength on the one side, but a lot of this is going to be coming from spinal musculature. So we'll be talking more about that when we get to the trunk and spine. Okay, let me switch over to this. All right, when we start talking about pelvic motion, you get really cool aspects, because when we think of upper extremity, very rarely do we have a situation where you have the shoulder moving, like I'm doing shoulder flexion and extension, and it's 9 times out of 10, it's the humerus moving relative to the shoulder capsule. Now, if I hung on a bar and did a pull-up or a chin-up, now my humerus is staying stable and my torso is moving relative to my shoulder. So you're getting an inverse action of the joints. In the lower extremity, this happens pretty regularly, where if I look at hip flexion and like I could let me see this. Yeah, perfect. So I can, both of these images right here, the joint action is hip flexion. In this aspect, you have the femur moving relative to the pelvis. No, I'm sorry, that's not it. Yeah, here. Now I don't have them superimposed. Okay. So this is hip flexion. This is the femur moving relative to the pelvis. This is also hip flexion. This is the pelvis moving relative to the femur. This is hip abduction. So this is me standing still. My leg is free to move, so it's open chain, so I'm able to move my leg out. That's hip abduction. This is also hip abduction, but now what's happening is I'm doing a contralateral hip hike. So I'll give you guys a second to process that you can either have the femur moving relative to the pelvis or the pelvis moving relative to the femur. The joint action is the same. The muscular participation is usually the same. It's just which end is more free to move. Are you in closed chain or open chain? So right here, whether the person's standing here and bringing their knee to their chest, right, that's standing hip flexion. When this woman's bending forward, this is also hip flexion. But instead of the femur moving relative to the pelvis, her feet are staying on the ground. Her torso is more free to move, so she's bending forward. So hip flexion. Dramatically different visually, but biomechanically identical. Any questions on that before I move forward? Because if I was going to study pelvis right now, I'd be studying mostly these type of relationships, understanding how you have femoral on pelvic versus pelvic on femoral relationships. So I'll give you guys a second if you have a question or you want me to review that. I think I have. If I don't have it, I'm pretty sure I have it. But if I don't, I will have this image extracted, because I think the Newman textbook does a really good job of looking at the. So you have this sagittal plane motion, this femoral on pelvic or pelvic on femoral relationship, and I'll have these in the Blackboard shell so you guys can look at these images for your viewing pleasure. Any questions? Remember, I can't see my chat function, so if you have a question, you'll have to.
What's an example of like closed chain?
So the easiest way, so these open chain and closed chain are borrowed from engineering, and basically what they mean is the predictability of the joint. So if something's 100% predictable, that would be a closed chain, right? There's no openings for any type of other options. If there's not predictability of a joint or a system, it's open, meaning that it could be X, could be Y, could be Z. the way that we look at it when it's applied to the human body, the easiest way to remember this is that it's usually talking about the arm or the leg, and you're looking at the distal end. If the distal end is free to move, it's open chain. So like in this aspect here, the foot's not connected to the ground. So so I could either be in the sagittal plane, I can come out a little bit. I have options. Like I couldn't 100% predict how this is going to be. So this is called open chain. So the foot's free to move. If I put the foot on the ground like I do here, this is called closed chain. So now the movement's happening above. Technically it's open chain above because the hand's free to move. But that's the best way of looking at open chain versus closed chain. I wouldn't necessarily try to just memorize closed chain. It's going to be femoral on or pelvic on femoral and vice versa. What I would really do is just see which is the more mobile segment. Which one is more mobile? In this case, is my leg more mobile or my torso connected to the earth? Is that more mobile? In this case, the leg is more mobile because I can lift it up. In this aspect, what's more mobile? My feet connected to the entire earth or my torso and the load I might be carrying in my hand? That's the better way of looking at it. I use the term open chain, closed chain because that's technically what it is, but it's better to conceptually look at it as which part of the bone or the body is more free to move. Is that helpful?
Yeah, thank you.
Okay, perfect. One of the things here that is similar to the upper extremity, remember you had a scapulohumeral rhythm that for every amount of shoulder motion or humeral motion you had, whether it's abduction or flexion, you had a related scapular movement as well. The same thing happens here, that you have a lumbopelvic rhythm. And for if she's not showing it here, but if you were to stand up and fully touch your toes, that you're not just getting all that motion either exclusively from the femur or exclusively from the lumbar spine, that you're getting at both. It's both hip flexion and spinal flexion that's occurring. And everyone has a little bit of different availability. It depends on flexibility, resources, and stability. But you have a lumbopelvic rhythm that exists when you bend forward to touch your toes or pick things up, that you have, it's a combination of both hip flexion and lumbar flexion. This here is showing closed chain or pelvic on femoral internal external rotation. So here's neutral. And then to achieve internal rotation, you can either have your leg straight and you can turn your feet in. So pretend this is my hand. But in this case, you kept the foot neutral and you turned your pelvis to the left. So left pelvic rotation was creating internal hip rotation on the left leg. In this case, you have the foot external rotation in open chain. If you had femoral motion, your foot would turn out. But since the foot's connected to the ground, it can't move. In order to get that same aspect, my pelvis is turning away. The end result is exactly the same. It's just looking at so this is just this image here is looking at this image here. So looking at the pelvis. So actually, for once now, the clinical kinesiology book is a better text. This is a better image kind of depicting that. And then just like with the upper body, we have force couples. In the force couples, we're looking at the anterior posterior pelvic tilt. And for the anterior pelvic tilt, that's the force couples are going to be the erector spine and then transverse spinalis muscles we haven't gotten to yet, but the back extensors. And then the muscles we're going to get to in this unit, the hip flexors. And then your posterior pelvic tilt is going to be your abdominal musculature and your hamstring. And they should have a view of that. Yeah. So here you'll see your abdominal musculature here. That's kind of pulling up on the pubic symphysis and then pulling down on the ischial and the posterior ass of the iliac crest. You're going to have your hamstring, your hip extensors, glute medius, glute max, and so forth. And then same thing with the lateral movement. You're going to have your hip abductors here. So your glute minimus, glute medius, and your TFL. And then you're going to have your lateral trunk flexors here. So your obliques and your erector spinae on that side. So again, on the pelvis, do you have a force couple of going into an anterior pelvic tilt, posterior pelvic tilt? And if you turn this way, do you have the force couple of a right hip hike, left hip hike? And then you have your, you don't necessarily have a force couple because it's independent of gravity of your pelvic rotation. And that's it. So that's pretty straightforward. There's a lot going on here biomechanically that so this will get more complex, but not more complex. It's going to be more involved. That's a better way of saying it. When we get into the trunk and spine, as you can see, there's a lot of carryover between that. And then it'll, as we start, and when we get into the next one, when we talk about the hip, which we'll talk about next week, you'll see that almost all the muscles that connect to the hip anchor through the pelvis itself. And so it's dependent upon those. So there's not a lot to go over here right now. Like I said, the biggest things would be really understand the relationship of an anterior posterior pelvic tilt, understand those force couples, and then understanding the femoral on pelvic motion and the pelvic on femoral motion. If you have a grasp of that, it's going to make trunk and spine is the next exam, but not next exam, but next unit. But as we get down through the kinetic chain into the lower extremity, particularly when we talk about hip, and then almost all the muscles that control the knee, all of them but like one or two, they all cross the hip as well. So any questions? Let me actually pull up Blackboard real quick. I want to see my
Hi, I got a quick question.
yes.
Okay. Are we going to be having another session next week?
Yes. Oh yeah, that's what I wanted to talk to you guys about too. This is actually probably one of the biggest turnouts I've had so far for people on the call. So I know Thursday, I put the survey out for Thursdays, but Thursdays just didn't work because I was planning on being on campus. But I think Natalie and a couple other people had sent me some schedules on when you guys have lab times, and I know quite a few of you are working. So I do want to pick a time that's going to be the best turnout. Even though you guys didn't really ask that, there was like 2 questions. These are recorded. When I remember to record, I have not forgot to record them, but we've been remembering to record them. But what's going to be the best time for everyone?
I'll be honest, this time on Fridays works for me best. I don't know about anyone else though.
Fridays don't work for me because I usually have to work.
Okay.
Yeah, it gives me the whole week to actually focus on like other classes and also on yours. So by like Friday, I have read the chapter and like done the stuff. Because by Tuesday, it doesn't give me enough time.
Okay. So you would like the opportunity. So my thought with these live sessions was to kind of be like a preview to kind of get you started, and then you would dig through the material and watch videos. But it sounds like you guys would rather watch the videos first and then be able to ask questions if there are questions. What do you think's I can do 2 live sessions a week. I can do like a preview live session that's like an introduction, and then I can just be available for questions, like nothing really planned. I don't go through the chapter and just have questions answered. So I could do like a Monday or a Tuesday live session where we kind of go through the chapter material, and then I can do like a Q&A at the end of the week, Friday and Saturday. For me to hop online, it's super easy. So. Let's do this. I'm just kind of thinking out loud. But what I'll do is I'll put another survey request out. Now, instead of putting specific dates, I'll just have people shoot 3 or 4 times that work best for them, and I'll just put the limitations on what I have already commitments for. So like my classes that I actually teach on campus on Thursdays, and then I'll float that out where we can possibly do 2 sessions where we'll have one that's a regular, even if no one's on there, I'll just do a chapter review, like a quick summary to kind of get you started, some of the key points to look at through the chapter, some of the key points on the video, and then I'll do another follow-up session in the week I think it was Adriana that said that, to give you an opportunity to consume the material, start digging through it a little bit, and then answering any questions or reviewing any of the sticking points that might be there. I think that sounds pretty good, actually.
Yeah.
Yeah, that sounds
Perfect.
good.
Okay. Good. Any other questions?
No, it's just next week we're going to be focusing on the hip, correct?
Correct. So this week is pelvis, and then next week is hip, and then the week following that is knee, and then we get into like foot and ankle. I think foot and ankle is combined. That's what I was going to look at real quick. Yeah, it's another good book.
Yeah, it's
Okay.
combined.
Yeah, it's combined, which is good because the ankle is like the foot and it's the same thing with wrist and hand. Wrist and hand should have been combined too. I don't know why this book did that, but perfect. Well, if there's no other questions, you guys have a good weekend. And so as of right now, we're scheduled for. Well, I'll send that out for the weekend, and we'll shore up a date we'll shore up our times for next week. So I'll do that today. Send that out. See if I get the survey back in response, and I'll set up 2 times for next week. We'll do a chapter review for the hip for let's see if it is the hip. Yeah, we'll do the hip for next week, and then we'll do a follow-up Q&A at the end of the week.
Okay, thank you.
Perfect. All right, you guys have a great day. Chris, you want to stay on and we can do our meeting?
That's fine.
Perfect.
Thanks.
Cool. Excellent.
I'm gonna get some lights here though. Yeah, when I was taking the test, it seemed a bit more daunting during, but then after I reviewed it, it really didn't seem as bad as it was taking it. And I saw some of the easy mistakes that I made. The one was I got the question wrong with the hammer, doing pronation supination. I listed both pronators for some reason.
Yeah.
It was just an obvious wrong answer.
I actually zeroed it out because there was a 96% miss rate on that. So
surprised by that too. I thought I just accidentally was one of the only ones who get that wrong, but that's a really high percentage to miss that.
Yeah. Yeah. So that's why I started to look at when I see things like that, I can't blame the students for that. That means there's something on my part. So I think what happened is I don't think people were expecting that type of question. So that's where I think the quiz is going to be a good learning tool for just reminder to really look at concentric eccentric from a practical application component.
Practical application component for the test questions.
Yeah, like that.
We have a great success rate if we were able to have class and meet in lab and actually physically move through, because the labs in the book, I don't know about for anybody else, but it's difficult if you don't have somebody else to work through them.
Yeah.
I could see how people could kind of brush that off or move quickly through it and really not grasp the concept that isn't terribly difficult to understand. It's just they don't get the time to physically do it.
Right.
So that's kind of the challenge with online classes.
No, and I think that's true too, especially this class, because this class, it needs that. These labs would be better if we were doing them in class together, and then key points. I'm really excited to teach this class next year when we're actually live on campus, and so you guys are kind of getting the short end of the deal a little bit. Luckily, you do have some time on campus with because aren't you guys taking ortho right now, or are you guys don't you have an orthopedic class now? Yeah.
Mm-hmm.
All right, so I actually going to pull up your exam, and I'm just going to open up. I'll share the screen, and if you want to kind of go through and ask any questions on.
Yeah, I wrote through everything, so if you can pull it up just to see, I didn't do too poorly at all, really. No, surprisingly, with all the nerves.
Yeah, you did well. I expect it, but I did expect you to do 85 because you're on the top end of the students. So So that's what gave me. That's what gave me the heads up. There might be something going on here.
So when for the amount of studying that I did, which was excessive, it just wasn't successful. I was surprised to have such a low grade. I thought that I'd be somewhere in the mid 80s range, like I said, email. But then I'm finding with multiple classes that I can talk myself out of the right answer, or I think, oh, this is too direct of a right answer. Maybe it's changed up and I'm missing something. So then I boost myself out of it unnecessarily, which that's a personal problem. But like I said, I reviewed the questions, and in all honesty, at first when I took it, this was my understanding. I was upset because I didn't do poorly, or because I did do poorly. And then I'm like, man, these test questions were several layers deeper than I was expecting. But then I took a break. I came back. I looked at them, and I'm like, no, this is simple anatomy, origins and insertions. If you don't have that, there's no room for error. Like, you're going to get it wrong if you don't have that. And then there, like, the questions you asked about movement, in my opinion, were completely fine, but it just goes back to not being able to actually get up and move and learn with people. And that was probably the biggest challenge for people. But looking at my test specifically, like, I looked at the ones I got wrong, and there were 2, 3, 4. There was probably 4 that I should have definitely got right out of that. One of which being, like, describe the movements of the. I, for some reason, picked roll instead of spin, which I know definitively that it would be considered spin. So I don't know, like, why I selected something like that. But then looking at this exam as a whole, let's see. So one of the things I wanted to talk about I think test question number 1. Okay. It was someone needing to work on scapular depression. I think for whatever reason, I looked, and tell me if I'm wrong here, did I kind of answer that with serratus anterior and pec minor, thinking more along the lines of like a winged scapula, or that still wouldn't apply here?
So what's your question again? If it's like
for question 1, I had, it was someone who needs to work on scapular depression training. The answer was pec minor and lower trap, which I get it. That's easy to see for scapular depression. But I was trying to think, was my mind going towards like the scapular with more winging out, and would the serratus anterior and pec minor contribution, would that help with the scapular winging, or still no?
Yeah, I mean, I think it's a perfect example of you overthinking the question a little bit in terms of, right? I mean, serratus anterior is a go-to muscle for scapular winging and for if you need scapular stability. But this is specifically looking at a non-clinical aspect, just looking at can you connect the joint action with the muscular participation. Chris, I lost your audio. Okay, there you go.
Oh, okay, sorry. Yeah, it was a direct correlation of me just kind of overthinking it. And that seems to be like a common trend in getting some of these questions wrong. Other than that, I mean, we don't have to go over any of the origin insertions, like getting tripped up on.
How about this one?
CRB.
How about the question 13 here you see on the screen? I think your question 13, your questions are going to be different because the questions are posted in random order.
Oh, okay, so, I gotcha.
Yeah, so this one you got wrong. What was your thought process there on that guy?
So in terms of visualizing the traps, I know that I thought that it just passed by the scapula. I didn't remember that it actually had it inserted on there. I thought it was just really close in proximity, and I just didn't make that direction. So I went with pec major.
Okay.
Well, that was just a trip up on like easy.
Yeah.
Okay.
The anatomy.
So from the sacrum to lower ribs to the base of the scapula, to the humerus. And I was like, okay, am I remembering that it does attach or it doesn't? And those fine lines of, I think it's just passing by before that.
Well, so it sounds like you're confusing the latissimus dorsi with the trapezius. So remember, latissimus dorsi does go from the sacrum and it goes up through the ribs. But the trapezius is the guy coming down from the top, from the neck, base of the neck.
Upper, middle, lower. Yeah. Okay.
Yeah. Okay. Cool. Yeah. Outside of that, a lot of it was just.
And I got tripped up on like teres major and the motions for some reason, and several questions that were applicable to multiple muscle functions. That kind of screwed me over because I forgot that. I just didn't remember to make the connection that the teres major had involvement with extension, so that got a couple of question wrongs, I think.
Yeah, but all in all, you did really well. I mean, so you still were in the top 25%, top 10% of the class. So I lost your audio again.
Sorry, that's how bad we did.
Yeah, it was as an average. I'm gonna change the blackboard. You guys are gonna see but I think the average on there was like a 67% was the average. So if you got above that, I mean, there was 7 people that failed the exam. So almost, yeah, like a third.
With what is the percent of failing? Is it the overall grade in the class for the PTA prefix class is 76, but
Yeah,
not for each individual exam?
Yeah, for this class, it's okay because it's a there's not it's not a skill check. It's just it's all lecture. But if it was a lab exam, then there would be issues there. But since it's what's it called? It's only lecture. It's fine. This is one of the classes that doesn't need to have a PTA prefix. It could be this could be like a biology class or a kinesiology class, but just the way that when Rita and I did the curriculum, we made it a PTA class. Yeah, I keep on losing your audio feed for some reason.
Sorry, I don't know if I'm just like kind of drifting off or. One of the questions, and I think this was, so for the hammer again, would it change anything if the forearm wasn't in neutral? Like you're you're doing standard, hammer as your resistance, pronation, supination movement, right? That's really common. Would it change anything if the arm was in extension versus neutral? Not really, right?
If show me
Just having your arm out in front on the table as opposed to being neutral.
Okay. It actually would in that case because when your elbow is at 90 degrees, your bicep long head of your bicep brachii can be a really powerful supinator. If you extend out, you lose that because now you're doing shoulder internal external rotation, right? So there's actually
that still wouldn't involve, because the answer that I put down was the two pronators. That wouldn't correlate that anymore, correct?
No, if you now took your hand and you went, I don't know if you can see me here, right? Now, if I change my rotation and gravity, if I go from this position and I go this position now, since it's an anti-gravity, now pronation is done by the pronators because it's concentric action, and supination, or actually that was supination, pronation is now done by the pronators. In this situation here, now I'm under the effects of gravity, and now I'm bound by.
The one question that I was surprised that I got tripped up on was the isometric with the extrinsic muscles.
Yeah.
So I'm trying to visualize it, and I'm like sitting here trying to do an isometric with my hand as I'm taking the test, and I'm like, why would I put myself in either of those two? I was like, okay, well, if I'm neutral, do I have a towel or a squishy ball that I'm just trying to do wrist Somehow I went into wrist extension. I neglected the finger flexor part of it. And then I'm like, okay, well, is the hand around a dowel rod in which it's not moving and it's just flexing? Or am I resisting with extension? So I had all sorts of weird thoughts with that question, which I should be a lot more straightforward.
I want to see how it's worded. I want to see the question again.
Oh yeah, it says isometric strengthening of extrinsic finger flexors in a shortened position.
So yeah, okay. So that would look like this. If I want to do in a shortened position, I would flex my wrist, and then I would do some squeezing activities here, like with a ball or a towel and again, it doesn't matter if the exercise is real or not. I don't know if I would ever do something in that position. It was just to understand the whole concept of passive, or in this case, active insufficiency. Because a lot of people miss this one too with the long head of the bicep, where if you wanted to maximally shorten the bicep, and you would do elbow flexion and
flexion.
Yeah.
So I got that one correct, and I didn't.
So the exact same thought process for this one.
Okay, so I didn't make that connection that it was another active insufficiency.
And I think because we spent some time talking about grip strength, that your grip strength, that you're maximal with wrist extension because you're trying to avoid active insufficiency. Your body's trying to spend time in mid-range. You're going into wrist extension as you're maximally trying to increase your flex. And if you go into wrist flexion and finger flexion, you actually get weaker. So I think
decrease your strength. Yeah.
And I think that's probably when I try to rationalize, like, why do people make the mistake? And I think that's the case, was that I should have chose a different exercise, different thing, but the wrist extension. But I think we did talk about like the grip strength a little bit. And
No, we did definitely, but just for that, in that question, because I was visualizing. So let's say that we are going to place a patient in that position, right, to a shortened position to do an isometric of the finger flexors. Like, so you're saying if it's a actual, like, real exercise or not, it's moderately awkward, right?
yeah.
It's okay. Okay.
Yeah.
So, because I'm like, all right, what functional thing? I was like, all right, I do wrist and finger like isometrics regularly. I'm like, why am I having a hard time with this question? Why can't I grasp, no pun intended, the concept here? So that, I guess, like, trying to create the image of the actual exercise was a challenge for me.
Yeah. I do apologize. There would be some circumstances where the exercise isn't real, or it would be a really, which it probably should be. So I'll keep that in mind for the like real case situations. Like, for instance, how that question would appear for the lower extremity would be looking at how do you manipulate the your length tension relationship. So, for instance, like glute hip extension. If you did hip extension, a hip extension is done both by the glute max and the hamstring group. And if you wanted to cripple or impair the hamstring, so the glute's doing most of the work, you would perform knee flexion first and then do hip extension, so that the glute is taking on more of that responsibility. So that's how that would post itself in the future for. Yeah, I lost your audio feed again.
Sorry. Yeah, I'm just saying, okay, I'm just agreeing. Yeah, that makes sense. And then really, everything else was just simple origin, insertion.
Yeah, and there was a couple of questions that didn't have a right answer, like the carpal tunnel one, like which of the, and I'm sure people spent some time trying to think through that. So that probably drained some time. But I should have proofread. It's Holly's fault. This was Holly's exam from last year that I changed a little bit. So
actually, one of the questions I was going to ask, and hopefully you don't mind me asking, but my thought to it when I was thinking about the levels of depth in the questions when I first took it and realized I didn't do as well as I thought I, was able to, or I'm able to do. If it was like call it a pre-COVID written exam, and I'm like, okay, well, is this an exam that was written for a group of people who were together in class functionally doing this, or was it modified for the online setting? So, and I was just wondering if that had played any part in the role, or could have.
If it was up to me, I would write brand new exams. But the way that, since we're under accreditation review, every exam, every question has to be accounted for. So I have very limited flexibility in my ability to change the exams. But I would use all of my exams from my previous class, because I think those are better. They're more in the. But Holly and Rita sat down and created these exams, and they have to connect it with all these outcomes, and just until we get through that accreditation process. So we're kind of bound by that a little bit. But yeah, because honestly, I thought there was way too many questions on wrist and hand, too many attachments. I mean, there's only so many learning objectives for that. I wish there was more on the practical application, but then we get into the issue, like you say, in terms of we're not in class together to kind of go review those materials. So
yeah. No, overall, it wasn't a terrible exam. The questions make sense. They're fine.
Yeah, I guarantee that everyone's going to do better in the next exams, just because you're not going to have the hand detail, and then as we get further through, you'll have a handle of how to study for it. People are going to crush it. So I am not concerned. It's just making sure that we move forward from it. But
thank you, thankfully, and thank you for it, giving us the option to have a review quiz or study guide, whatever, just to have some other questions before. I think that'll be extremely helpful, because it's a different format than your review questions in the back of the book.
Right. And to address your statement earlier, that's where a lot of people, like when you look at learning and you look at like the metacognition of learning, a lot of the issue is that when you just do review, you convince yourself what you know and you never really identify what you don't know. And the best way to study is actually taking like quizzes and doing flashcards. And so I know of like Quizlet, and there's a bunch of things, a bunch of resources online where you can go and take anatomy-like questions just to kind of force yourself to go through that. But or the even better way of studying is like you as students, you guys try to come up with study questions yourself. Like, how would you write an exam? How would you quiz your classmate? And then you guys kind of distribute those questions. That shows the limitation in your thought process and like, where am I missing? And so that's like the best way of studying is you creating a quiz for your classmate and a classmate creating a quiz for you. And the process of you going through making questions and then actually answering your classmates' questions, that shows true holes in your thought process. But if you just review, you're just confirming the things you already know. You never really know what you don't know.
Yeah, that's a good idea. I mean, like you can memorize left and right, but if you can formulate your own questions and get a deeper understanding and then kind of review as you are teaching a class, that's obviously many levels deeper and more advantageous for you. Well, I mean, really, that's it for the questions that I had for the test. I know you really quickly scrolled through there, so it's not like you probably saw too much of focus to work on for next time other than some of this memorization stuff.
Yeah. I don't know if you can see this book right here, this Teach Yourself How to Learn. It's a great book. I mean, it's a great little, if you can, it's usually $11, but I guess the price is going up, everything. But it gets into that whole aspect of how do you, and maybe not even this book itself. I mean, you can check out the library, but let me think here. What's the, oops. No, this is it here. You don't even have to get the book, but if you do a search on her, she has a lot of information out and a lot of blogs, but she has let's see here. If you just go to the website, like that whole quiz thing is just talking about how the brain works, and I got that from this book. It's a great book, and it changed the way that I taught, but it changes the way that you learn as well, and understanding the best practices for. But if you just, my internet's getting slow here right now, but if you look up Powerful Teaching and just look up the author for that, you don't have to buy the book, but there's tons of like free resources that you can use for how to change the way that you approach studying. It will dramatically improve your retention. And not so much, I mean, it sounds like you're doing a pretty good job here, but particularly for your license exam when you sit for that.
All right, well, I wrote that down. I appreciate it. I appreciate your time, Jonathan. I do. Thank you.
Perfect. All right, if you want to meet again, let me know. Cool. All right, Chris, take care.